Dr. Mrinal Kanti Das. I am the immediate past president of Cardiological Society of India. It's a great privilege that I have been selected for giving the oration on Dr. K.K. Date Memorial oration. My subject is definition of heart failure as well as management, a new perspective so that the CSI leadership can take up some of the points from my oration for forming their own position statement or focus statement. The points what I wanted to highlight, that we are just having the old concept of definition of heart failure and its management by explaining everything with a single entity. Mind you, this is happening for over the years. But what has happened with this? There are certain and many heart failure mimics like anemia, thyrotoxicosis, acute myocardial infarction, cardiogenic shock, and all these arrhythmias, they can contribute to the heart failure, and the focus is disarrayed. Now, my point is that if we take out the mimics, cardiac heart failure mimics out of the system of definition, and we just focus on the real definition of heart failure, that is where there is structural or functional damage of the heart failure with an ejection fraction less than 50%, with rise in NT-proBNP. And with this definition, if we focus, then possibly the management of heart failure will be much more easy, much more applicable, and much more barrier free. Now, what are the barriers? There are various barriers, like in the form of doctors' inertia, patients' inertia, and systemic inertia. What are the doctors' inertia? Oh, my patient is doing very nice, very fine, so what should I do? Let him continue the medicines and all, without objectively finding whether the patient is overloaded or not, whether the patient is having some form of arrhythmia or not, whether the patient is having adequate medication or not in the prescribed dose, or as per the guideline mediated directed therapy. So these are some of the doctor's inertia. What about the patients? The patients will have inertia. They will not buy the medicines. They will say, oh, I am fine, so why should I take medicines? Doctors will always prescribe the medicines. I need not require all the time. And if they take the medicines also, that might be subtherapeutic. They may not be helped by other people. That is a systemic failure. There may not be any monetary support or insurance coverage, and there is no follow-up system. So all these inertia ultimately lead to the therapeutic inertia, and they are responsible for failure of pursuing the guideline mediated directed therapy of heart failure management. Now, again, there are various classifications of heart failure. Most are known and based on ejection fraction. If it is less than 40, heart failure with reduced ejection fraction. If it is more than 50, heart failure with preserved ejection fraction. If it is in between, we call them heart failure with mid-range ejection fraction. But over the years, there have been several other changes by which several other names have been coined, like heart failure with recovered ejection fraction. From minus 40, negative 40, it is coming to say 45 or 44, like that. So, recovered. But again, there are certain kinds of heart failure where it's totally improved. So, heart failure with improved ejection fraction, HFRIEF, improved ejection fraction. But another new concept has come out where there is functional effectiveness is compromised or not compromised. So, heart failure is functional ejection fraction. Many times this kind of the classifications are very, very important for leveling the patient as well as for accurate management of the patients. Now, apart from that, this, what I am proposing really in my topic, that there are other classifications also to be added, like heart failure with advanced failure, means there is no kind of improvement with any drugs or devices. I am not going into the device part, but definitely I will talk something about the drugs part. So, no devices, and they are refractory heart failure. So, heart failure, they are refractory heart failure, and sometime even beyond that refractory heart failure, it is the end stage heart failure. We cannot do anything with those cases, and they are to have actually the palliative kind of therapy, palliative treatment, supportive measures, and they should lie in the home and they should be taken care of, basic medicines. Now, what are the drugs that are of importance for heart failure management? There are very, very important drugs like SE inhibitors, ARBs, ARNIs, then SGLT2 inhibitors, then comes diuretics, then comes the ivabradine, then comes MRA. So, all these drugs are very, very important along with the beta blockers. Beta blockers, you know, there are various kinds of beta blockers, but the most important ones that are used are metoprolol, carvedilol, and bisoprolol. So, they are very much commonly used for heart failure management. In fact, a prescription without having these drugs should not be labeled as a correct prescription. Now, initially the step care therapy was followed, that every 2 weeks the drug will be escalated, drug dosage will be escalated, and gradually within 6 months they are to have the proper kind of doses if they can tolerate. But nowadays that has been abolished. Within 4 weeks, 4 drugs of heart failure must be there. One is ARNI, second is beta blocker, third is MRA, and fourth is the ivabradine. And now again fewer other drugs, the diuretics and vericiguat and all other drugs are being tried here in the management of heart failure, and various trials are showing very good results with those drugs as well. And definitely the time will say whether they can come, say especially for vericiguat, whether they can come to the guideline or not, only future will tell. So, the message from me is that we should think about lone heart failure where all the cardiac failure mimics are ruled out, and we are focusing on the heart failure management. Then the management will be better, as it happened with the hypertension management, where primary and secondary hypertensions were defined, and when the secondary causes were excluded, only the focus was on primary hypertension, the management of hypertension became much more secured, much more official, and much more acceptable, and they could be followed up well. Same way, heart failure which rules out the mimics, that is lone heart failure management, also might have the same kind of things if we follow the guideline directed medical therapy, and of course the checklist, which is very, very important factor in the management of heart failure. If we really do the checklist and tick that this patient is having this drug and those drugs in this dosage and continuing with the medications, then and then only we will be having the reduction in the burden of the heart failure and thereby the reduction in the mortality of heart failure. Thank you all.